Welcome everyone to the Chromatic Connection. It's another year with exciting guests and exciting stories. So let's take a seat back and listen to our stories this year. Welcome everyone to our first episode for 2026. Today we will be discussing a very important topic which has to do with childhood health and childhood obesity, whether it is lifestyle or genetic complications. So today we'll be welcoming Dr. Reham, who's a pediatric and endocrinologist, and we have met Dr. Reham last year in our type 1 diabetes children's episode. Welcome, Dr. Reham, back.
Thank you for having me, Fatima. It's a pleasure to discuss with you this vital topic related to children's health.
Thank you. And could you just give us a little bit of background to our new audience about yourself?
Yes, sure, Fatima. I'm Dr. Reham Ghanim. I'm a pediatric endocrinologist currently practicing in Dubai at GluCare Diabetes and Metabolic Center. And my field focuses on managing cases related to children's obesity, diabetes, all types of diabetes, type 1 and type 2, problems related to hormones like thyroid hormone, adrenal hormones, and growth hormones, which affects the children's growth and activities and overall well-being. And also, importantly, cases related to puberty, whether it's late or whether it's early, and what we will cover today.
So, Doctor, today, could you explain to us what is the status of childhood obesity in the region right now? And what are the factors beyond diet and exercise that contribute to the problem of childhood obesity in the region?
Obesity is a significant global health concern now, and UAE is seeing a concerning rise in the prevalence of severe cases. And to understand obesity, we should know that it's not only a simple food and energy equation, or it's just simply a willpower issue. It's more complex than that. Many factors can contribute to the increase in the prevalence of obesity worldwide. And most importantly, if we mention some of these factors, let's speak about poor sleeping can induce imbalance in the hormonal pathways, and this can lead to increase in the tendency of obesity and the tendency of developing fat in the body. Stress, for example. Stress and well-being are essential factors. Stress can induce a hormone called cortisol, and cortisol increases also the fat predisposition in the body, and that's why it's very important to address this point. The lifestyle that we see these days, it's changing towards a sedentary lifestyle where everything is available. You can get everything delivered to your house. No need to move. You just move your thumbs on a PlayStation, which is not enough, of course. So sedentary lifestyle is scary, and we should address that. And finally, environmental factors, and this is an important point. Certain environmental factors are called obesogens. These like plastics, cosmetics, pesticides, etc. These factors can changes also the balance between the hormones and can affect how our body regulates appetite and feeling full. So these are a few examples of some risk factors.
And yes, we can see that very much because with social media, we have the kids on TikTok till like 3 in the morning. As you said, everything is so accessible, so there is no movement. Also the pressure in terms of maybe how they look on social media,
Exactly.
the pressure of also obtaining this lifestyle that they, pressurize people that they should have. So there's a lot of stress factor that they live with expectations.
Yeah, which increases the disappointment, increases the like the stress burden,
Yes.
and this is a cycle of being demotivated and then ending up just on the phone or on the screen, scrolling up or playing games, feeling that it's a struggle that is difficult to overcome. And here, when we need to interfere, cutting this cycle and showing how a system can support families and children or teens to reach to their goal of having a healthy body, healthy metabolism, and then at the end, of course, better lifestyle.
Yes, and interestingly, also you said, like, for example, the environment with the plastics, also cosmetics, because now there's this whole controversy of how, like, 10-year-olds are using cosmetics, and there is so much, chemicals in that, and it's harming. So they are exposed to so many different factors that would cause, as you said, the addressing of the causes for obesity. So, doctor, how do you differentiate between the struggles of obesity with a child where it is contributing to a lifestyle factor, or is it because of genetic complications?
This is a very important point, Fatima. Thank you for asking this question. Genetic obesity usually comes more severe and very early in life. It can start even in the first few years of life. And it can be associated with other features, like, for example, small hands or feet, a very constant urge and a constant feeling of hunger that is not fulfilled by normal meals, which we call polyphagia. And also it can be associated with behavioral problems, with developmental delays. So these features are red flags to highlight to us as specialists that there is something else is going on, which can be hormonal or genetic problem. To add on polyphagia, conditions like Prader-Willi syndrome or some single gene defects can cause some of these features. And it is important to address these cases because they require specific medical treatment, not just behavioral or lifestyle treatment. So that's why the specialist role is essential to do a comprehensive evaluation of the child's case.
And could you elaborate on the treatments?
Nowadays, we see a major advancement in the available medications to treat children's obesity or adolescents' obesity, and we need to know that these medications are breakthrough, but they are not magic pills. They should be used with caution under a medical supervision and in a systematic way, integrated into a multidisciplinary and holistic approach. So to mention one of the most important breakthrough in the medical management is what we call GLP-1 agonists. They are ideally proved from the age of 12 years and above. But sometimes we need to use them even as off-label to smaller ages in cases of severe and early onset complications or specific genetic conditions. So to explain more, these medications work to mimic a natural gut hormone that stimulates insulin production and increases the body sensitivity towards insulin at the same time. And it also motivates feeling full, so it induces appetite and it slows down the stomach absorption of food. So all this will help to control not only to control, to improve the insulin resistance and also to help with weight loss. So as a result, these medications are really amazing invention. But at the same time, They are linked to side effects as any medication, and they can lead to both fat and muscle loss if they are used and not supervised and not supported. So it's very important to know that these medications are started for cases who fail to achieve the goal with lifestyle alone, or with those who have severe obesity and severe complications. And the use of these medications is together with the lifestyle, comprehensive lifestyle therapy. And lifestyle therapy will include a dietitian support to explain what is a balanced, correct eating habits, not only crazy restrictive and calorie deficit diet, which is very serious and scary to be implemented in a growing person, a growing child. So that's why a dietitian role is vital for these patients. And also the emotional support. As we said, cortisol, which comes from chronic stress, can increase the tendency to build fat. So we and also, of course, the social stress on the child, the family stress, because they want to support the child, but also they don't know what is the right tools. Sometimes it's the opposite. It adds to the burden of the emotional status and the well-being. So it's important to also address that. So as specialists, we look for it and we address if we notice any signs of anxiety or depression in the child or in the family, and we seek the right advice by referring to a special psychology centers who are focused on eating habits and eating disorders. So this is to create an environment which is supportive, not judgmental, to reach to our goal, which focuses on building a healthy routine, healthy habit, and not only to reach a certain number on the scale. This is super important. I always tell my patients, when you come to me, we will forget numbers. We will not look at numbers. This is my role to evaluate the numbers in a proper way. But for you, you need to focus on your lifestyle. Your reward to yourself is based on the achieving the goals in improving your lifestyle. Like, for example, did you have your 1 hour walk or exercise, whatever you like? We mention always the aerobic versus non-aerobic exercise, and we address all that. But at the end, you have a time allocated for exercise every day. You have you need to have your regular meals. I want my patients and children's teenagers to have breakfast, lunch, dinner, and I teach them about the proportions, the types, and of course I get more help from my colleagues in the nutritionists and the dietitians, as we mentioned before. So did you achieve this by eating your healthy meals and removing the fizzy drinks, the additional sugar, the junk? This is a goal by itself. Did you achieve that through the last week? Okay, then you need to reward yourself. If you did not lose any single kilograms, I don't care. This is not our goal. Don't weigh yourself on the scale. So I see this as a very fruitful way to achieve both weight loss and improving the overall metabolism and lab results and overall health.
Yes, absolutely. I do agree with that. And this is what actually I always say to my niece and nephews when it comes to, like they're at the age now, they're very conscious about how they look. And I tell them, I'm like, the important thing is that you are healthy.
Yeah.
It is not how you look, it is how your lifestyle is and how you're healthy long term.
Yeah.
And interesting, the point you made also in terms of the parent support. So here I feel also what would you advise, for example, parents from their perspective? How would they help these children to within the house? Because as a doctor, you have your section that you're supporting them. So in the house, as parents, what are the key tips that you would give them to follow in the house? So we said, for example, nutrition, maybe the idea of everyone eating healthy helps encourage the child.
Yeah.
In terms of also, you said the reward system, but putting it in their mind, it's not about what you're on the scale, it's about your number showing you're healthy, you get a reward. So what other factors or tips do you advise the parents to follow to prevent and support children with obesity?
This is super important. Children are children. They are not still mature to lead to lead the way to reach to their goals. So they always need the support by their parents. And to achieve that, always we say we want a family oriented and a family based approach. So as anything in life, you need a partner to support you, to encourage you. The first one is to seek help from your parents and family. And then also we look at the cousins, friends, we include them in this circle. And how can we achieve that in practical tips is to have things together. For example, we want to encourage healthy eating habits. Number one, don't bring all the snacks and put them in the store and say no one is allowed to open and eat, because this is like it's like making them suffer. It's like army, training. So especially at the beginning, because it's already a challenging phase, let's help them by removing all these, unhealthy, attractive food, processed meat, chips, chocolates, sugary drinks. No need. Don't bring them home. They will still, kids I know, they can order from Talabat and online, I know, but to put it available at home makes it even easier to just give up on this.
Yeah, as you said, they're gonna access it, but at least it's not at home and it's not continuous.
Exactly, yeah. To make some effort to reach to the unhealthy food, so we make it less frequent. This is number one. Number two, put all the healthy options available at home and seen. So many times the parents tell me, my kids, they don't like vegetables, for example. They don't. And then when I ask the child, give me one option of one vegetable that you like. And they say, for example, okay, I only like cucumber. I say, okay, no need to eat all the healthy vegetables in life. It's okay, choose some and make it always available, ready in the on the table in the living room. When they open the fridge, this is the first thing to be visible. All these things are simple tricks, but it helps because teenagers specifically are lazy. And I know we should always teach them how to be proactive and seeking healthy habits for themselves, but at the end, and life is not perfect and we need sometimes to support at the initial phases. So this is one simple, very helpful trick. Number three is to have meals on the table as a family. In our daily lives, this is not easy because everyone is busy at work. The working hours in Dubai are long. But maybe if we can do that on a weekend only, it's good. If we can do that every day on a single meal, for example, dinner, it's better. If we are lucky to have an option to have breakfast and lunch and dinner, or breakfast and dinner, this is better. So as whatever we can do as a family, it will be good. So the healthy options will be on the table. Parents will encourage children because they also will follow the same trend. If parents are unhealthy, they cannot convince their children to eat healthy. If parents order junk, kids will follow that. So there is a responsibility on parents. I always whisper to the parents' ears that if you want to decide for yourself to live unhealthy life, do that outside the house. Do that alone. I cannot force you as a pediatrician, but I'll ask to not to bring these habits at home. The same thing is for physical activities and screen time, all that. Physical activity can be done also together. So a father can take his son for a walk, a mom can take her daughter to a class. Whatever works for the personality of that child. Like some patients, they used to tell me, but I don't like to go swimming, and they force me to do swimming. I always ask, okay, what is the kind of sport you like? Do you like this? Do you like? And whatever they choose is good. Especially always in the starting phase, we need to be easy and smooth, because otherwise it will not work. It's already a challenge to go, across this urge and food memory, and this is a real struggle. It's not only you don't have a will and you have a will. No, it's a real struggle that we need to be practical to achieve a goal at the end. So these are simple family tips that is helpful, and always bring your child for a checkup if you feel a resistance, if you feel that real efforts has been implemented without results, because sometimes hormonal factors can be the reason. For example, thyroid gland, which is a gland in the neck, produces thyroid hormone, which controls our metabolism and energy. It's very common condition to have hypothyroidism. Hypothyroidism means slow and lazy thyroid. And what does that cause? It causes easy weight gain, very slow metabolism, and other features like feeling fatigued, lazy, low mood, hair loss sometimes, constipation sometimes, not necessarily to have all the features. There's a lot of features. But I mean, one of them, because we're speaking about weight, is having a tendency to increase weight fast despite efforts. So we need to check that, and we need to treat it if it's, because the treatment is totally different. It's a hormonal pill every day, which is very simple and effective. So that's why it's important to check everything, not only to wait years saying that, okay, we tried diet, we tried, preventing access to food. And then parents and kids go into a vicious cycle of losing trust, because the kids feel parents, they don't understand their struggle. And parents start to believe that their kids are not up to their standards, or they are not responsible. And it's not always like that. And most of the time, to be honest, it's not like that. And parents' love is very sensitive, and sometimes it can harm unintentionally. Like I see that in the clinic when I see kids crying that I don't want to do this anymore, I cannot, all these words. Yeah. And parent and mother or father starts crying that I try to support, I don't want to see you ending up with diabetes and all that. Yes. And it's very obvious there is a need for help here. Yeah, whether it's there is a need for help always, and we should seek help again. As I always say, don't delay seeking help, because at the end you will just get more overwhelmed without reaching the result that you want.
There is that communication glitch. Like, interestingly, in my last episode last year, I was talking about like my body image. So as a child, I had meningitis, and they pumped my body with cortisone. Mm-hmm. So as you were saying, it affects your entire system.
Exactly.
And I had gained so much weight, and the struggle that you were saying, I could so relate to it, because like my parents tried their best as much as, they were given the information. But after a while, like after a year, 2 years, and the thing is, people don't understand that the cortisone in your body, it takes years to leave your body.
That's correct.
And I mean, the amount they had given me was a crazy amount. Yeah. So I always had that struggle where I wasn't eating, I wasn't anything, but because of the cortisone in my body, I was gaining weight, and the environment around me kept on saying, "Oh, you're not exercising enough, you're not doing this enough, you're not doing," and as you said, psychologically, it did affect me, because like I felt I don't know what to do, and now what's great is we have the resources. Like, for example, when you have the struggle between the parents and the child, kind of each one wanting their own goal, you have the coaches that can guide both the parents and can guide the child.
Exactly.
Another point I like that you said in terms of work with what is their interest. So even me as an adult, I'll honestly tell you, when it comes to exercise, I get bored doing the same thing. So that's why I vary from weights to Pilates to yoga to spin classes, sometimes walking on the beach. And this motivates me every day to get up and do some form of an exercise. So,
yeah, and this makes it sustainable habits, because if we force something that you don't like, you will never sustain it. And if it is the same thing every time, it gets boring unless you want it as a profession, to be honest. Because as you said, having a variety of activities makes this is what is called a lifestyle. This is what is called being active. Just to be mobile, active, having time to move, whether it's on the beach, as you said, whether it's going to a class, just to have this in the routine is what we need.
So can you tell us more about the complications of obesity?
Yes, so the complications of obesity are becoming more serious and more prevalent, because, as we said, the severe obesity trend is getting more and more. So nowadays we see children with type 2 diabetes, which is one of the most serious complications of obesity. And type 2 diabetes is defined by the body increased resistance to their own insulin. So insulin resistance or insulin insensitivity means that the body needs to produce a lot more of insulin to control the sugar in the body, because the body is not responding to this insulin. So at certain point, the body will feel exhausted, and then the sugar will go up, and it will end up with the full-blown type 2 diabetes. So nowadays, we try to catch this early by doing specific tests to catch insulin resistance early on. And we have more treatments available to help with the lifestyle, of course, to improve this condition. Now, very important to say, when the body produces more and more insulin to overcome this resistance and to control the sugar as much as it can, insulin itself is an anabolic hormone, and that means it's a building hormone. It likes to build fat, and especially around the abdomen or the tummy area. So this means that insulin resistance increases the tendency of having high insulin and building fat. Increasing weight and increasing fat increases and worsens the insulin resistance, and we go into this vicious cycle. Okay, which makes it even difficult to lose weight with lifestyle or with exercise. So we try to identify this early. We try to identify which patients have true insulin resistance and severe, to help them with the medications along with a holistic program. So this is one. Number two is vitamin D deficiency. It's very important to address this. Vitamin D deficiency is common anyway. It's common in UAE. Almost every child is vitamin D deficient in my clinic. And having increased fat in the body increases the tendency of having more severe vitamin D deficiency, which also what we see in the clinic. So it's very important to check that and treat it with vitamin D, and the dose depends on the level of the blood test, because poor bone health, whether it's nearby or long-term complication, is very serious, and we need to address it. Number three is, we mentioned already the thyroid. The thyroid can be affected by increasing body weight and by obesity, and it can, so the thyroid function test can be abnormal, but rarely it is serious when it is as a result of obesity. But as we said, it's very important to check it, because sometimes it's the reason for obesity, not the complication. Another thing is high cholesterol, high fat on the liver, which we call fatty liver, and And finally, even musculoskeletal problems like joint pain, joint problems from the excess weight on them. A condition called Blount's disease is when obesity at long term can lead to bowing of the legs. And another condition called slipped capital femoral epiphysis, which is a condition affecting the hip joint, leading to pain and unstable movement, unstable gait, and painful gait. So these are very important complications, and we see them in teenagers. We see type 2 diabetes. We see teenagers who needs multiple medications to control their sugar. We see very high cholesterol levels. We see severe fatty liver nowadays. Whether it's because the screening now is more available, the awareness is more, so we started to detect these cases also earlier than before, or also the trend and the prevalence of severe obesity is more. I think it's a mixture of both, because the numbers don't lie. The prevalence of severe obesity is truly more than before. Each year is dramatically more than previous years worldwide and in UAE. And also because of our new techniques to discover these complications.
Very interesting. And I was honestly very shocked when you tell me that cholesterol has become a very high percentage in children. Like, this is really shocking to me.
Yeah, high cholesterol is a very interesting topic in kids, because we see high cholesterol in kids. People get shocked, like, really high cholesterol in this age? I say yes, and we have even more advanced markers now we use, because not only the simple lipid profile is what we need sometimes more tests to discover if familial risks and genetic risks are there. So it's important to check the family history also. If the family history shows that there is multiple family members with early cardiovascular events like early stroke or myocardial infarction, or if parents know that they have high level of cholesterol, this is a red flag that there is a genetic factor. And nowadays, the worldwide guidelines recommend screening all children universally, regardless of the risk, between age 9 and 11 the first time, and between age 17 and 20 the second time. But if there is a family history, the screening should start as early as 2 years old. And why is that? When screening is encouraged, it means there is something that we can do to prevent long-term risks. So we have treatments now, and we can start statins, which is the treatment for high cholesterol from early age, and it can dramatically reduce the risk for long-term complications and having sudden death in early adulthood. The side effect often very tolerable. I want to highlight this because people think statins means failure of the liver, problems in the muscle. Traditionally, there are side effects like this for statins, definitely. But the newer statins are more tolerable, and we can use them in less doses, and we can combine them with other treatments that work in a different way, for example, to control the absorption of the cholesterol from the gut. So it's very important to believe in in this, and to seek early checkup, especially if there is family history. All this comes, when we speak about family history, all this comes under what we call familial hypercholesterolemia. So familial hypercholesterolemia is genetic, and it will not change. It will always be there. And the high cholesterol starts from birth. So, and the damage to the blood vessels starts from birth. It just, when the manifestation appears very clearly, it's early adulthood, most of the time when it is genetic. But when you start treatment earlier, all the complications are delayed or prevented. So it's very, very important. I always like to speak about this in any chance, because I see underestimation of this, or running away from this topic, or denial that cholesterol is linked to adults, not to kids. So why we mention this? Because we're speaking about obesity, which even worsen the the cholesterol metabolism and increases the bad cholesterol, what we call LDL, and increases the bad carriers also, what we call ApoB. So these are carriers of the cholesterol. So it's linked to our lifestyle, it's linked to our diet, it's linked to obesity. But having a genetic factor in addition, which is also common, will make it very scary. And we need to check for that.
No, that's also excellent because, as you said, if you can prevent it from childhood, and the fact that you're saying from 2 years old and from birth, at least you can prevent a lot of heart complications that come in adulthood due to that.
Yeah. You know, there are symptoms in the skin, for example, white skin lesions, what we call xanthomas. It can appear, but should it appear all the time? In all cases, no. There are signs in the eyes, but sometimes and most common manifestation of high cholesterol is sudden death. So we should not wait for that. We should be very proactive. So this is very scary, and this thing I learned it from my mentor. And he always used to say when I used to do my training, he always used to say the most common sign of high cholesterol is sudden death, and you should not wait for it. So I took this as a message that I need also to educate more people about it.
Yeah, absolutely. And like nowadays, you're seeing so many young people are just suddenly dying of heart attacks, and they're like as young as like 21 years old, you know? So it's very true. And most probably this must be the case, as you said, that it's like long term and it's something that can be prevented.
Yeah, this is not something uncommon. We hear this. I think most of us heard it at least once, that he's in 30s, working, doing exercise also. But all of a sudden, there was a sudden death, and then in the hospital they said there was a sudden clog in the vessels or a sudden myocardial infarction. So that is most likely the reason. There are some other possibilities, but this is most likely the reason.
So now I'd like to ask you about puberty. So do you feel that obesity can affect the puberty in terms of slowing down the process or having certain delays due to obesity with puberty?
It's actually the opposite. So obesity can causes early puberty, and this is very important to highlight. So why is that? In girls, obesity and body fat can produce estrogen, and this can start puberty and can start the whole, process of hormonal changes early. Also, in both boys and girls, obesity can advance the bone maturation, and advancing bone and skeletal maturation can end up with early and precocious fusion of the growth plate, which means that children can look tall at certain point because the bones advancing and they're growing taller. That's why you see obese. I don't want to call it obese, but I mean kids or teenagers with more weight tend to be also huge, like taller, but not necessarily to end up with taller height, because sometimes when the growth plates fuses prematurely and early, this is the end of the growth journey, and the final height is not necessarily matches the potential. It can be less than their potential. So definitely gaining weight, excess weight, and obesity can fasten the process of puberty, leading to early or precocious puberty.
Going into that, for example, for the girls, so with this also, I'm assuming that it affects in terms of conditions like PCOS and so forth. So can you tell us more about that?
Fatima, this is very important that you ask about PCOS or polycystic ovary syndrome, because some people think it's a taboo. They don't like to talk about it because they feel embarrassed by speaking about things that lead to excess hair or excess acne. So first, what is polycystic ovarian syndrome? It's a condition that is common in girls and women, and that leads to increased insulin resistance and increase the production of male hormones. This is the essential point, that it increases the production of male hormones, which can lead to excess facial hair or body, unwanted hair, acne, the fat in the belly area. And it can affect the periods regularity. So it can be irregular or it can stop also, like periods can stop. And it can also affect future fertility. So this is very important because there are also available treatments, and when things are addressed early, treated early, then you prevent all these complications. It's very important to speak about this early and openly. We do test for this by doing a physical assessment and a blood test. So ultrasound in teenagers is not the essential point to diagnose PCOS or polycystic ovarian syndrome, because in the early years after having or after starting the menstrual periods, it's very common to have cysts in the ovaries. It's very common to have also some irregularities in the period. So we rely mainly on the physical assessment and the hormonal evaluation. The Rotterdam criteria, it's like a criteria to identify people at risk or to diagnose people with polycystic ovaries, were revised for adolescents and for teenagers to include blood tests to evaluate for the male hormones, for the insulin resistance, and to look at the period, of course, regularity, but does not focus on the ultrasound features. This is very important because sometimes girls, they come with the ultrasound showing cysts and they panic, but they don't have any of the other features. This is not PCOS. And sometimes the opposite, people with and girls with true features of PCOS or at risk of PCOS, they tend to hide and feel ashamed. So we need to educate. There are treatments. It can vary from pills to control the insulin resistance, or birth control pills, or lifestyle also. It depends on the severity and on the case. Also, it's very important to highlight that some of the cases are not related to obesity or not related to insulin resistance. It can be also related to a gland called adrenal gland, and most of the time this is a genetic condition. So the adrenal gland is the part which is responsible for producing a normal, acceptable levels of male hormones in the females. So if there is a condition with this adrenal gland producing more male hormones, this also can lead to features of PCOS and fertility issues and all that. So that's why it's very important to get checked by a specialist to look at the things as a whole and to identify the root cause of the problem, and then to give the right treatment.
And so in this scenario, this is female teenagers. Is there a condition for the male teenagers that are, something relating to this topic of their hormones?
Yes. So in male teenagers with obesity, they usually suffer from excess estrogen, which comes from the fat tissue, leading to gynecomastia, which is visible enlargement of the breast tissue. What they call gyno in the schools. They always come tell me that I want to check, I have gyno, I want to know how can I treat this, because this is embarrassing, in the swimming classes and all that. So it's very important to know that puberty itself, the puberty stage, can produce estrogen. There is estrogen production in this phase. And there is a common and a temporary phase of gynecomastia during this. But obesity can increase this, and sometimes it can last. It can, like most of the time it's temporary, it can resolve, but sometimes it can persist, especially when the obesity is there. So it's important to know that obesity increases this. So lifestyle, treating obesity, helping the child will help, of course, going into the transient gynecomastia thing, and improves the result, helps with the resolution. Sometimes we need surgeries, but this is one of the important things that I like to address, because many mothers or teenagers mention it. Yeah.
Yeah, I know. You see, these two factors I can see is very common, and that's why I wanted to discuss the PCOS, because I see it a lot in the region, and I see it a lot later on in life. People having problem with fertility.
Yeah.
So I feel it's a very important topic for our region, because my question here is, do you think that this also has something to do with the genetic structure?
You mean obesity, or you mean
with the hormone issues? Do you feel it's sort of the genetic structure of a region? Do you feel that this is one of the factors that maybe why it's a higher percentage?
Definitely, I see that. We need more studies to evaluate on a bigger scale let's say the Middle East, or the Gulf region, or the Arab region in general, because we see tendency of genetic causes of polycystic ovarian syndrome, where I mentioned it can be only related to simple increased production of male hormones, or more complex causes in the pathway of this adrenal gland that controls the male hormone production from the start. It's like a chain of or a cascade of events and enzymes, and it's a big pathway that sometimes we need to dig deeper. We look at each component of this pathway to know where is the defect and to treat it in a certain way. And it's a very important thing. It can be related to infertility. It can be related to even more complex complications in the future pregnancies. And usually consanguinity or cousin marriage increases the appearance of these genetic problems, which is also more prevalent in the Arab region. Not all ethnicities or not all countries have a tendency of cousin marriage, but it's more common in this region. That's why genetic conditions in general, and for example, PCOS, genetic causes or adrenal problems can be also more prevalent. So it's super important to check for that in any girl presenting with PCOS, because we tend to identify girls and we tend to treat them differently. We tend to give them advices differently, even after they lose weight. And it's most of the time a lifelong thing. That's why I'm very careful with labeling a girl with PCOS or labeling her with some of these diagnoses. It's something that is there for your life, for the rest of the life. So, and the management is lifelong. So it's different than just, helping with, for example, weight loss and then everything returns to normal. It's different entities. Yes. So, but the presentation is the same. And we need to be aware. As doctors, I always urge doctors to refer when they feel there's something wrong, but regardless of their specialty, whether it's general pediatrics, whether they are, whether gynecologists also dealing with ages like 12, 13 years old girls, because the scope is different when you deal with kids growing to their teenage years. And knowing all this, you look at the patient differently than dealing with other conditions most of the time and then addressing such a condition. So I always ask my colleagues to refer when they have doubt and to know how to identify patients who can be who can have manifestations. And also I like always to explain to the parents, because they are the main doctors for their kids. They are the first source to catch any abnormality. So I hope that
Yes,
explains a little bit
no,
about
that's
it.
true. And as they say, it takes a village to bring up a child. So,
Yeah.
it's a whole team basically that you have to invest in. Very interesting.
It's a complex topic, so sometimes it's confusing when we discuss it, but I hope we can simplify it to just understand the main points and not to panic if we identify anything. As sometimes I don't like to feel that I deliver a bad news when I speak about these things, because it's not bad news. It's okay, anything related to our children's health, we want it to be perfect, but our body goes through changes, and some of these changes are pleasant, some of it might not be. But when we check things and when we identify things early, the end result is better. Like when you identify PCOS early and treat it, then the chance of having fertility is excellent. But when you just close your eyes and you don't want to, get the news, that the girls end up with going to IVF centers and fertility center, thinks there is something, like something very big going on and all that. So I mean, it's always good to look at things early and to look at the root cause of things.
So shifting now from speaking about obesity, now we would like to talk about the opposite, about poor growth, and what are the red flags we should look out for.
So growth is one of the vital signs. It's a very important point we as endocrinologists rely on to identify many cases with chronic illnesses, with poor nutrition, with hormonal issues, or with genetic problems. So, so growth is a very complex, it's a very complex process. It relies on many things. And in the clinic, as a pediatric endocrinologist, we do a full assessment starting with a very detailed history when we evaluate a child with poor growth. So we start from birth. We look at the weight at birth. The baby was born, or the child at birth was born with a normal weight for his age or her age at birth, or smaller for age, because most of the babies or most of the children with history of small for gestational age, they catch up at the age of 2 to 4 years. But if they don't, this is a sign that their body needs growth hormone to reach to their potential. Then also we go in the history for detailed nutritional assessment, looking for any sign of nutritional deficiency that we can address and treat. That's why also dietitian can be valuable, and we also look at any sign for chronic illness or malabsorption. Like, for example, we screen for celiac disease, which is the gluten insensitivity, when the gut cannot absorb gluten, and it also cannot it affects the iron also absorption. So this can lead to poor growth. Sometimes conditions related to the gut where it's inflamed. It's called inflammatory bowel syndrome. So I mean, we dig deep to look for signs of all these conditions. We look at medications, what the child has been using for long term. Like, for example, kids who used corticosteroids in their childhood for long time can have a poor final height, because cortisol, like a corticosteroid, can suppress height gain. Children with ADHD on certain medications can also be affected for the height and puberty also. So medications are important. We also look for the family, the pattern related to height, related to hormonal issues in the family, non-genetic conditions in the family. We evaluate the parents' height, and by simple equation, we evaluate what was called the mid-parental height, which is to evaluate the genetic potential of that child. So to see that the child is growing along with that genetic potential or less. Because if the parents are very tall and the child is somehow acceptable in the regular growth charts for the general population, we should not only say that the child is growing, acceptable in that chart, but sometimes the child is way below his target or her target compared to the parents. So this is a red flag also. So we check that. We do a comprehensive physical evaluation, like from head to toe. We check puberty stage. It's very important because puberty and growth are going together, and puberty means that the growth is accelerating at one point, but it's aborted at the other stage. So puberty is very important to be identified, and puberty is stages. So there are 5 stages for puberty, and we know that most of the time it takes 2 years to complete this journey. So we try to put all this together to understand what is the time left for the child, what else we can, what is the intervention suitable at that stage. We do a hand X-ray to assess skeletal maturation, and this is very important. It's like part of the physical examination to evaluate the skeletal maturity. We look at the bones. How does the bone look like? Mature appropriately according to that certain age, according to that puberty stage, or it is late or it's advanced. So late, significantly late, bone age can predict hormonal problem like thyroid or growth hormone problem. If it is very advanced, it can first it shows that not much is left, and also it can indicate other problems, and sometimes it's just puberty being very active, advancing bone age, and that's also a sign that we need to slow things down by certain interventions, depending on the case. Sometimes we need to do specific blood tests. Now, generally, we do blood tests always to check, as we said, also to check the general well-being, like the basic test, the nutritional assessment, and general hormones like the thyroid hormone test, and the growth factors levels. Sometimes we do stimulation tests to stimulate growth hormone by certain agents. Most safely are some proteins called like a protein called arginine can be used safely to stimulate the growth hormone production and see if the stimulation is appropriate or not. This also can help to add to the overall picture and to help identifying patients with growth hormone deficiency. Sometimes we need to do an MRI of part of the brain to look at a gland called pituitary gland, which is the main central gland producing or controlling all these hormones related to growth and puberty and cortisol and thyroid. So we look at the size of the structure if we have doubt in the hormonal values. So all this, of course, is a process to identify the root cause again. So if it is a case where the child needs thyroid hormone, okay, this is the treatment, we monitor, we observe. If it is a growth hormone deficiency, we give growth hormone in a monitored way to balance between the benefits and to avoid any potential side effect with appropriate monitoring of the dose and the duration of the treatment course. If it is celiac, the treatment is just gluten-free diet and, of course, referral to the gastroenterologist. If it is, sometimes it's diabetes at the end, like diabetes, which is not identified, cause weight loss and cause poor growth. If it is especially type 1 diabetes. Sometimes other autoimmune diseases can be identified. So, I mean, that's why it's not only like poor growth is linked to growth hormone or it's related to diet only. It depends on what people get exposed to. They think it's only that, but it's not like this. It's a very also holistic approach, and also we screen for psychosocial factors like stress, because stress again increases cortisol, and cortisol not only increases the fat and the weight, but also it suppresses growth. So neglect can be one of the reasons. Severe stress at home can be a reason for poor growth. So a lot of things we address. We go comprehensive. The first evaluation is very comprehensive, very detailed. We get to know the patient from A to Z, and that's why usually it takes 2 to 3 visits to start to direct ourselves to which, because the first time is when we meet and take history and exam, then next time when we discuss results, then we do some imaging if we need. So this is how we make sure that we give the right treatment for the right cause, not just blindly.
And I had a question here. So I know like a lot of parents have an issue with giving growth hormone treatments.
Mm-hmm.
Because, as we said, it's another sensitive subject when it has to do with anything that where you're altering the hormones. So how would you convince a parent who is scared to, start treatment of growth hormones for their child? Like, what is the proof you can give them to give them some ease that this is something that is good for their child?
So I always go with educating patients about and parents about the my thought process, like how I do things, why we need to do a certain investigation or treatment. So I have a big screen in my clinic at GluCare. We start from showing the growth chart. Where is the child now compared to the general population of the same age. So when they see that the height is really below the lines, this is one thing to make them feel that, okay, we need to start doing something, not to wait and say maybe they catch up. Number 2, when we check the parent's height, we add to this, like, okay, your child is going really below the potential that you both are giving them. Number 3 is when we highlight the points in the history, the diet, the examination, all that. Number 4, when we do the tests and we show, okay, these are the growth factors. So speaking about growth hormone, we look at the growth factors. Growth factors are protein in our blood produced under the influence of growth hormone. We don't check growth hormone randomly, blindly, because growth hormone is produced from the pituitary gland as pulses. It's a pulsatile production. So we cannot check it randomly. The pulse might be there, might not be there. So we check these factors. So when we see that these factors are low in a concerning way, this is also something that the parents see as evidence that, okay, we need to do something, and the doctor shows us evidence that it's related to growth hormone production, so most likely our child needs that. Then we do also extra tests, because to be honest, for us, we don't prescribe growth hormone easily. We really go through multiple procedures to make sure this child needs growth hormone, and we have FDA approved criteria to prescribe growth hormone for certain conditions, and growth hormone deficiency is one of them. There are many other conditions, like children with renal failure, children with genetic conditions such as a condition called Turner syndrome, children who were born small for their gestation. As we said, the birth weight is really small. So there are certain criteria, and we follow that. We follow the evidence. We provide parents the time and the resources to read and to educate themselves. And I'm open to let the parents take time to think, to ask if they want more opinions, to read, and then they come with confidence when they see that, okay, the information is true, and all the evidence is there to support this decision. And when we also explain how we monitor the effect and the side effect and how we deal with that, so they feel safe that okay, we're connected, there is a plan for everything. So also when we do the hand x-ray and they see that the bones are really small, like they always come and say, my child looks like 6 years, but my child is 9 years old. So how come? And when we do the bone age is 6 years. So okay, there is something real going on.
Relation.
Yeah. So that's why all the body is processed for a 6-year-old child. Even their nutrition need, their growth pattern, puberty pattern will follow that. Okay. So that means there is something that the body lacks, which makes the body cannot, proceed as the speed needed. So, which is most of the time growth hormone when it is identified. So, and I always say, okay, you have a factory producing hormones, and they are producing other hormones in a good way, but this machine is not producing growth hormone, so we just need to support it with extra supplement. Or it's the same thing as you give vitamin D to vitamin D deficiency, you give growth hormone to growth hormone deficiency. And we have now more attractive devices also. So some people, they like the simplicity and they like pens because growth hormone is injection. Most of the time it's a daily injection, but now we have also weekly injections. So it's injection using a pen, like insulin pen or like the weight loss medication pen, the GLP-1s. They're all pens. They are easy to be used, but now we have even more advanced devices, something called EasyPod. It's like a device and it's connected to our computer, so I can monitor remotely the compliance. I can monitor the doses. I can monitor usually the first month. Definitely I check multiple times this chart. I make sure that the child is comfortable using the machine correctly, giving the right doses, not skipping any dose, because we know that skipping doses with growth hormone means you don't reach to the optimal response. So I check that, and then later it's the checking. I check in the clinic with the patient every visit. So I show them that, okay, everything is here recorded, so make sure you take your injection. And now the device, for example, EasyPod can control the depth of the injection, the speed. So most of the time there is no pain. So that's also important to give the parents comfort, because usually they get scared from injections. So I always show all the devices in front of parents. If I feel that patients are not comfortable with technology and they want the simplest thing, we go for pens. If I feel that parents know they like technology and the children, especially, the children's age, they like technology. They like also, it's linked to an application which is related to a growing body, we call it. So the body is as like a figure in the application. It's a boy or a girl that grows also with the patient. So these things makes a difference not only to the patient but to the parents, because it eases their journey with the treatment. And we explain how we meet, how we monitor, how we adjust the doses, and we give all the resources to get help when it's needed. So all this, if you see, it's very detailed, that at the end, the parent will not be at the same level of acceptance at the initial visit compared to the visit when we conclude what is the right treatment for that child.
Yeah, no, this is excellent. And this is also what I like about GluCare. It's more about the education of the patient, walking them through, giving them options. And as you said, like even with the technology for the child, they can learn about their own body, by having this monitor, putting it in a way where, as you said, it's something that, they find cool. Yeah, exactly.
They have different colors, different stickers.
So it helps them understand their body growing up. And honestly, with any form of like disease or illness or like chronic disease, it's all about you understanding your body, and nobody's like body is the same.
Exactly.
So this is I mean, I would be convinced. Definitely. And interestingly, you had mentioned Turner syndrome, correct? So could you explain what it is and more detail about it?
Okay, this is important because Turner syndrome is an important cause of poor growth and, let's say, short stature in females only, but it's not very well known, and but it is there. And Turner syndrome is a genetic condition. So we know that females are identified by having a female chromosome, which is XX chromosomes. So what identifies females is XX chromosomes. What identify males is XY chromosomes, right? So girls with Turner syndrome, they have one of this X syndrome missing, the whole X or part of it. Now, if we have the classic Turner syndrome, which has many features, all cells in the body will have a missing X chromosome or part of it. So it leads to manifestation related to a height, and then later on fertility issue and puberty, delayed puberty or like a poor puberty. And they have like a streak, very small, underdeveloped ovaries. That's why it affects the puberty and fertility. They can have problems with the heart, with the kidneys. So this is the classic Turner, not necessarily all features to be there. And usually in childhood, it's mainly the growth and these, heart, kidney, features. And then in adolescence, mostly it's related, mostly the care will be focusing on the puberty and the fertility thing. And then in the adulthood, in addition to fertility, it will be also hypertension, high cholesterol, diabetes. All these are more at risk. So, and with modern technology and modern reproductive technology, now there is a chance for them to get pregnant with donor eggs and with certain cases, of course. But most interestingly is the mosaic Turner. So, what is mosaic Turner? It's that not all cells in the body have this missing X chromosome. Some cells have normal XX, normal chromosomes, normal genes, all normal, and some cells have the defect in the X chromosome. So these girls, most of the time, they don't have the classic typical Turner. And I forgot to say that Turner syndrome can have also distinctive face features, which I will not elaborate now, but I mean they can be identified by looking at them. But mosaic Turner, usually they don't have these. They can have everything is normal, only height at the early childhood phase, only the height is affected, very tiny. So that's why when we do the screening for the other stuff and we don't find anything, but and usually they don't have delayed bone age, they don't have the features of growth hormone deficiency, and we rule out all the other nutritional, other hormonal stuff. So for girls, we do the chromosomal test to make sure if they have this mosaic Turner condition or not, because they need growth hormone and they need it in a certain dose, like usually higher doses. And they need to be identified because we do checkup for the heart, for the kidneys, for the uterus, for the ovaries, and we keep monitor them until puberty. We know that they will not go into puberty. We need to give hormones to kick the start of puberty, and it will be a different journey. It's not an easy diagnosis at all because, it's a genetic condition with all these features that we mentioned. But also, again, not diagnosing them and just giving them growth hormone blindly means you are treating part of the condition. So again, the holistic approach, the comprehensive evaluation, the true diagnosis is important.
And my question, you mentioned about the features that you can identify in a Turner syndrome. So can you tell us a bit more about that?
So in classic Turner syndrome, they have specific facial features, and they can have features in the neck. So they have what we call webbing of the neck. So there is like a web of the neck.
Yes.
They can have low hairline. So the hairline can be low. They can have wide shield chest. Nipples can be separated with a longer distance than usual. So these are some features. They can have some also skeletal problems, like with what we call it, the wide carrying angle. So like this, the elbows. And of course, very important when we do the ultrasound and we look at so a very good radiologist is needed, because ovaries are not always easily seen in kids, and we need to see the ovaries, and we need to see that they look streak, so they are very small, not developed. So that's a key factor in the diagnosis.
And you had mentioned to me a condition where about the height of an individual, you said that when they are sitting, they're a normal height, but when they get up, they
yeah, we were
very
chatting
short.
about this outside. So there's a condition. So if we speak about the general term, there is a condition called skeletal dysplasias. This is the general term, where the problem is with the growth plates. So the growth plates have a problem with the signaling of the signaling which leads to growing at that area. And because of this genetic problem, the growth plates will not grow and will look abnormal on the X-rays, and even by grossly by the eye. So there are a lot of conditions under the umbrella of skeletal dysplasia, but the classic and very commonly one, which now has treatment for it also, is called achondroplasia. And achondroplasia is also genetic, but it can be due to a gene which is inherited in what we call autosomal dominant. Like, it means you need just one defect in one defective copy to have the full disease. And sometimes it's not the parent who pass this, it's just a random change, what we call de novo mutation. And sometimes it's parents and their families with achondroplasia. So what is achondroplasia? I mean, how they look like. It's the most common cause of short limb dwarfism. So the limbs, the extremities are short, very short. The trunk is not short. So when we do the assessment, we always look at the upper segment, which is the trunk, and the lower segment, which is the lower extremities, and we look at the ratio. So if the upper segment is good height or tall or acceptable, and the lower extremities are short, then this is a sign that we need to think of this. So achondroplasia, usually, as we said, when they sit, they look fine, but of course their legs will not reach the floor. But when they go to the floor, you will see that they are very obviously short. And they are very intelligent, and they have societies to gather themselves, to support themselves, because they are intelligent and they function very well in life. Everything is fine. It's just that because of the bone growth and the bone maturity is not happening in a normal way, they get struggle with their daily also functions. For example, driving cars, now they have special cars for them because they cannot reach the petrol pedal, for example. Going to the bathroom because of the short extremities, they cannot clean themselves. This is very important to address. This is very important to think about. So it's a real challenge. It's not only a matter of being short. There is daily daily things.
Your lifestyle, your
Exactly.
routine. Yeah.
Especially when you have a smart brain and you cannot function the basic, daily routine properly. This is a constant struggle.
Yes.
So in the old days, that the solution for this condition was surgery, which is limb lengthening surgeries. They cut the bones, they do rods, and they stretch, and it was a long procedure. And it's still there, it's available, and of course we always recommend good centers, because as any procedure, it should be done under a proper center and proper surgeon. But nowadays the good news is there is a medication called Viscerotide, which is FDA approved for this condition. It's an injection, and it changes the it's just substitute the absent or the defective part of the pathway, which is led by the genetic problem. So it overcomes this problem, and it helps the growth plate when it is given in a growing child. It helps the child to grow their limbs, to grow their hands also, so without surgeries. So it is an amazing, and like I know cases, and I know they receive the medications available in UAE, and we saw the response. So that's why we chatted about this, because not always it's growth hormone or nutrition or even hormonal in general. Sometimes there is long list of genetic conditions that can affect stature and height, and nowadays all these rare diseases are under a big society to support them and to support research to develop treatments for them, because it's rare, but to them and to their families, this is their whole life. And and awareness should be more about it. Awareness that treatment is available should be also more, and available about registries and about support groups is important, because this is where people meet and learn from each other, and where also the medical society benefit because of research opportunities for these patients to support them. Yeah.
Thank you, Dr. Reham. We really spoke about a lot today, and thank you so much for giving us all your knowledge and the options that are out there. So I would like to ask you, my last question is, so what message would you like to give everyone about metabolic and pediatric health?
My final advice is to be an active, informed partner in your child's health. In pediatric endocrinology, time is health and time is growth. You know, we spoke about a lot of topics, whether it is growth-related issues, whether it's obesity, and whether it's familial hypercholesterolemia. Early detection saves a lot of long-term complications and improves the quality of life for the child. I always say in endocrinology, emergencies are limited. We can count them. But the quality of life is what makes our specialty special. So identifying kids with a certain cause for poor growth and treating it will change dramatically the life of that child. So giving growth hormone in the right time will save height. Giving treatments for teenagers with early puberty or for kids with early puberty will also save from the emotional stress from early puberty, and also from the ending up with a short height. Also giving treatment or identifying kids with insulin resistance and type 2 diabetes early will save from the complications and from the cardiovascular complications later on. Identifying children with familial hypercholesterolemia also early and addressing that, treating it early, will save them from sudden death from early cardiovascular complications. So really, time is health. And I always advise seek help early, get checked early, don't delay the time for checkup.
Great. Thank you so much, and I wish you all the best.
Thank you so much, Fatima. It's always a pleasure to be with you.
Thank you.